Good afternoon, ladies and gentlemen. Welcome to ICS webinar, and thank you for joining us today. I am Emre Huri from Ankara, Turkey, working at Hacettepe University, Faculty of Medicine, and the Department of Urology. I am also director of the ICS School of Modern Technology. Today, we are going to talk about the post-prostatectomy incontinence and the technology-based approach. Before the panel introduce themselves, please make sure you post any questions and your comments you have for us in the comment section below, and we will get to them as we go along. I would like to present the two valuable experts, Sherif Mourad from Egypt, who is an ICS past General Secretary, and David Castro Diaz from Spain, who is an ICS General Secretary. For me, great pleasure to be with you. Would you introduce yourself, please, Sherif and David?
Hello, everyone. I'm very happy to be with you today. I'm Sherif Mourad, Professor of Urology in Shams University, Cairo, Egypt. I was the past General Secretary of the ICS, and I'm still serving as the chair of the Committee of the ICS Developing World. I hope you enjoy this webinar today with us all together, and I will leave David to introduce himself.
Thank you, Sherif. Good afternoon, everyone. Welcome to this webinar focused on post-prostatectomy incontinence. I'm very happy to be here, and I also hope you enjoyed this webinar and it's fruitful for you. Emre?
Thank you so much. Now I'm sharing my screen. And David, actually, nowadays we are living very unprecedented times, and I would like to ask you about how your urology clinical practice affected by COVID outbreak. Can you give some information about this?
Yes, thank you, Emre. Certainly, the coronavirus 19 has clearly impacted our clinical practice, particularly oncological procedure, prostate cancer including, and as a consequence of that, also the treatment and management of benign conditions. So, because the pandemic, some actions taken in urological department include the cancellation of face-to-face and non-urgent activity, planned clinical appointment were screened, patients with non-urgent condition were consulted by telephone and rescheduled for a later appointment in a few months. Outpatient procedures were screened and stratified by urgency, and cystoscopy and prostatic biopsy were carried only in cases of non-deferrable condition. The same regarding benign condition. Next slide, please. So the European Association of Urology elaborated a recommendation based on the Office of Guidelines regarding the priority for diagnosis and management. So they consider high priorities that condition regarding incontinence when suspected when incontinence is probably due to oncological cause. And then regarding the treatment, they consider high priority only those cases which really can put in high danger the life of the patient within a frame time of 6 weeks. That's why we cancel or postpone many of the procedures. Next slide. And regarding the post-prostatectomy incontinence, which is the topic we are going to focus on today, we have to decide how to prioritize the treatment of men with post-prostatectomy incontinence following the crisis. And it's not going to be easy. It may vary across countries and institutions. Will depend on severity of incontinence, because it's not the same to treat a patient with mild incontinence than severe incontinence. We also have to take into account comorbidities, the general health status, the time in the waiting list, particularly in a national healthcare system as ours in Spain, the healthcare system, of course, the availability of resources, and we, for sure, we will try to perform short day or day care surgery for both a sling and also artificial sphincter. Thank you, Edgar. I think that you can go on now with post-prostatectomy incontinence concepts and physiopathology.
Okay, thank you so much, David. Actually, we know that the post-prostatectomy incontinence is a condition that negatively affects the quality of life. I would like to remind the rates of the urinary incontinence in men. It can vary from the 40 to 80% for urge urinary incontinence, while the 10 to 30% for mixed urinary incontinence and 10% in stress urinary incontinence. However, the risk of the post-prostatectomy incontinence can range from 3 to 49% at 1 year, with a 1 to 5% with needed surgical correction for post-prostatectomy incontinence. Self-reported prevalence as high as 90%, and surgical treatment should be considered only after a period of 6 to 12 months. And we know that 12 months is the best improvement in continence for the surgery. So we don't need to wait more. PPI as a post-prostatectomy incontinence may occur also after some surgery for open prostatectomy and TURP and the other forms of treatment for prostate cancer. And the successive treatments may increase the risk of post-prostatectomy incontinence, everybody knows. Different anatomy-based functional outcomes of various treatment strategies on prostate may cause various types of incontinence due to severity of damage in incontinence mechanism. For this reason, AUA and SUFU guideline reported and informed us about the use of the term of IPT, incontinence after prostate treatment, instead of post-prostatectomy incontinence, a more inclusive nomenclature given that the management of patients who have incontinence after radical prostatectomy, radiation therapy, and all kind of the treatment due to on prostate. Differences in the definition of urinary incontinence can cause different results in the publications, everybody knows. When the common definition of success is the use none or 1 pet per day. Actually, it will affect the literature, especially based on the ceiling surgery that we are going to talk about afterward. What about the pathophysiology of post-prostatectomy incontinence, dear colleagues? However, it has 2 parts. The first is damaging during surgery. The second is the bladder dysfunction. During the surgery, the sphincter shortened and the layers mechanism disrupted, and of course the weakening comes on, and the blood supply and nerve supplies are negatively affected. So this is very important to understand the pathophysiology, especially to decide how we will treat the patient due to the severity of the incontinence. And everybody knows the stress type urinary incontinence is accompanied by 50 to 70% increased or decreased bladder activity with low bladder compliance. However, common sign of the detrusor dysfunction, bladder dysfunction, approximately 50% as a detrusor overactivity. And the pathophysiology of detrusor overactivity has some factors, including the neurogenic, uretrogenic mechanism, like anatomic, defunctionalized bladder, detrusor underactivity, and the bladder outlet obstruction. The risk factors for post-prostatectomy incontinence can be divided into 3 groups: pre-operative, perioperative, and the post-operative. They are the advancing age at the time of the surgery, and neurovascular bundle resection, the presence of anatomic stricture, increasing the body mass index, and high prostate volume, and the previous history of TURP, and the pre-operative, the membranous urethral length, and of course the surgeon experience and techniques are also important. Considering all of this, I would like to stress the importance of anatomy and the 3D vision during the radical prostatectomy surgery and for correction of the post-prostatectomy incontinence. The learning details of functional anatomy of the specifically prostatic urethra, proximal, and the distal sphincter are gaining more and more importance. Specifically, functional length of the urethra, angle, organs adjacent to the urethra, healthy epithelium, and the pelvic floor are fundamental parts of the anatomy. So, proximal sphincter consists of smooth muscle and works involuntarily, and the distal sphincter works and controlled voluntarily and consists of striated muscle. The other name is a rhabdosphincter that we can call it. I would like to show this picture at the midpoint of the prostatic urethra. There is a critical angle of 35 degrees as an anteriorly. This part includes the proximal and the distal parts of the prostatic urethra. Proximal part of the prostatic urethra includes the internal urethral sphincter. This is the mainly resected during the radical prostatectomy, and the distal part includes the upper border of the distal sphincter. This is anatomic importance for the critical angle to maintain the continence after radical prostatectomy. Due to some reports, surgical approach to prostatectomy do not seem to impact rates of post-prostatectomy incontinence. And now there is no current evidence that any surgical maneuver or any surgical technique beyond bilateral neurovascular bundle dissection results in improved continence recovery. That's why I would like to stress 3 anatomic points that make a difference: the apical and the basilar prostate shape, lysosphincter preservation, fascial planes of dissection. The lysosphincter means the internal smooth muscle. It anatomically covers the bladder neck and go through the verumontanum. So everybody now the bladder neck preservation during the radical prostatectomy means the preservation of the superior segment of internal smooth muscle sphincter as a lysosphincter. For the best urinary control, especially following the radical prostatectomy, we have to take into account the preservation, full length, integrity of smooth muscle, not only the striated or rhabdosphincter, and the preservation of the nerves, and we have to take into consideration that all periprostatic fascial region includes this nerve, and the fine dissection is crucial to preserve the nerves and the continence mechanism. However, prior to surgery, the determination of the healthy or damaged tissue where the anatomy is complicated in pelvic floor, in perineal region, which is impaired after prostatectomy, we'd like to thanks to exponential technology that will help us to see detailed anatomy. Actually, the 3D modeling, 3D medical printing help us for surgical planning, and also personalized pelvic and perineal surgery will be the big advantage for us. On the other hand, we aim to decrease the learning curve for training and for the surgical procedures, and it will affect the education and the training. We recently published one editorial for a better understanding of the 3D surgical anatomy, increasing visibility for hard-to-see structures. We can use routinely patient-specific CT or MRI data that will allow us the completion of virtual surgical procedures, surgical planning, and patient and student education. That's why I would like to stress that the implementation of the new technology into the management of the post-prostatectomy incontinence is a critical step for the future. Sherif, how should we manage the patient in this anatomically and the functionally complex situation, please?
Thank you, Emre. And hello again, everyone. The first step in management is the proper evaluation of the case. One of the most common tests is the PAD test. You all know about it. Sometimes urethrocytoscopy can be helpful in diagnosis of urethral or anastomotic strictures. The question is, do we need urodynamics to evaluate patients with post-prostatectomy incontinence? The straight answer is not always, but in some severe or resistant cases, we will need urodynamics, especially if we have a history of urgency urinary incontinence or voiding dysfunction, or before deciding surgeries such as sling or artificial urinary sphincter. Urodynamics can show the bladder capacity and compliance, or the presence of the Truser overactivity or urodynamic stress incontinence. Then we have to categorize the patient whether this is the case of intrinsic sphincteric deficiency alone, or the Truser overactivity only, or mixed of sphincteric deficiency and urgency incontinence. Next, please. This trace shows good compliance, but with evidence of the Truser overactivity with leakage. So this shows urgency urinary incontinence. Next, please. The abdominal leak point pressure is also important to evaluate the sphincteric integrity, and this can help in before deciding which kind of surgery will be applied. Next, please. Prior to surgery, can you go back, please, Emre? Another one, please. Before we go, can we? Okay, so next, please. Next. Okay, with the urodynamics, the evaluation is to characterize the underlying physiopathology, which may be useful to perform prior to invasive therapy. And in the presence of failed surgery, complex symptoms, and congenital anomalies, urodynamics will be definitely helpful. But we have to understand and to put in mind that there is no predictive value of urodynamic findings on the outcome after artificial sphincter or sling. This is important because otherwise urodynamics should be very variable, but because there is no predictive value, you need to be very cautious about this. Next. It is helpful sometimes to do cystoscopy, as I mentioned, and maybe use some imaging techniques to look at the urethral integrity, sphincter appearance during cystoscopy, the stricture, bladder neck contraction, or bladder pathology, and or doing cystourethropy, KUB, or ultrasound to look at for any abnormalities that can help you to decide. The reposition test is the maneuver that we ask to the patient to perform a pelvic contraction while the surgeon makes a soft pressure in the perineum in the level of the bulbous urethra. Through our direct endoscopic view, it was possible to demonstrate a good coaptation in the external sphincteric zone and hence to confirm a good residual function, sphincteric function, which will decide, give us, the help to decide whether a sling operation will be helpful for this patient or not. Next. This is the start with the conjunctive treatment. So, in a systematic review and meta-analysis of the evidence regarding the effect of preoperative pelvic floor muscle exercise on the post-operative urinary incontinence following radical prostatectomy, it was found that preoperative pelvic floor muscle exercise improves the post-operative urinary incontinence after radical prostatectomy at the 3 months, but not at 6 months. And this is just suggesting that it improves early continence, but not long-term continence rates. So this kind of conservative treatment does not improve the quality of life of the patient on the long term. And the recommendation is that to offer instruction on pelvic floor muscle training to men undergoing radical prostatectomy to speed the recovery from urinary incontinence. So one-to-one conservative physical therapy for men who are continent after prostate surgery is unlikely to be effective or cost-effective. High rates of persisting incontinence at 12 months suggest substantial unrecognized and unmet need for the management of these men. Next, please. Okay. So, in men who fail conservative treatment, other treatments can be considered. There are 3 advanced clinical trials suggest an earlier recovery of continence in men receiving duloxetine either alone or in addition to pelvic floor muscle training for the post-prostate surgery, stress urinary incontinence. And the evidence is that duloxetine either alone or combined with conservative treatment can hasten or speed the recovery of continence, but does not improve continence rate following prostate surgery, but can be associated with significant, albeit often resistant side effects. So this is, an evidence that this kind of treatment is not very effective, and due to the side effects, many doctors are reluctant to use this drug actually. Next, please. Injection of bulking agents has been used to try and improve the coaptation of a damaged sphincter zone. Initial reports showed limited efficacy in treating incontinence following radical prostatectomy. Also, sometimes this procedure is helpful in those patients who don't want to go through real surgery and with very mild symptoms that can help. The evidence is that there is no evidence that bulking agents can cure post-prostatectomy incontinence, and there is weak evidence that bulking agents, and next please, Emre. There is weak evidence that bulking agents can offer temporary short-term improvement in quality of life in men with post-prostatectomy incontinence, and there is no evidence that one bulking agent is superior to another. And as you can see, due to the weak evidence, the level of evidence is not very strong here. Let's talk about male slings. Fixed slings are positioned under the urethra and fixed by a retropubic or transobturator approach. The tension is applied during the surgery and cannot be readjusted post-operatively. I'm talking about the fixed slings. So for restoration of continence by this male sling, there are two concepts that are being proposed. The first is continence restoration by urethral compression, like the InVans and the iStop TOMS, and continence restoration by repositioning the bulb of urethra, like the Advance. In principle, of course, the artificial urinary sphincter can be used for all degrees of post-prostatectomy incontinence, while male slings are advocated for mild to moderate urinary incontinence, and this is important for the guidelines. If you look at the selection criteria for sling, you need to make sure that there is some residual sphincter function and that this proximal urethra is still mobile, and you need to have a PAT test around 24 hours less than 300 grams, more incontinent in the afternoon, and the patient can interrupt stream during voiding and can hold urine from getting up, and very important to be dry in bed. It is also not recommended after radiotherapy or previous urethral surgery. And during cystoscopy, try to look around the sphincteric anatomy, to ask patients to do voluntary contraction, retroluminal perineal support test can be done, and make sure that there is some mobility of the membranous urethra. It is very important to look at the urethral coaptation because this is the key of the improvement. A reposition test has been mentioned, and I think that we will talk about it later in the cases. Next, please. The advanced sling is also, it gives some better innovation for this kind of treatment, but sometimes it has some adverse events like retention, perineal pain, or rarely sometimes hematomas. Sometimes urinary incontinence was worse, maybe due to severe fibrosis or contracture. So it is very important to make sure that there is no urethral perforation also that happened during the procedure. Next. This is how it looks like, the advanced sling, and this is the cystoscopic view before and after applying. As you can see in the upper picture onto the right, that there is sort of advancing the proximal part of the bulbous urethra into the pelvis, from pelvis to the abdominal direction, to make some sort of continence in a way that prevent the leakage. Next, please. So the evidence is that there is limited short-term evidence that fixed male slings cure or improve post-prostatectomy incontinence in patients with mild to moderate incontinence. And there is no evidence that intraoperative placement of an autologous sling during the robotic-assisted radical prostatectomy improves return of continence at 6 months. Men with severe incontinence, previous radiotherapy, or urethral stricture surgery may have less benefit from fixed male slings, and there is no evidence that one type is better than the other. Next. Now, this is the adjustable slings. Adjustability in male sling surgery attempts to adjust the tension of the sling post-operatively. 3 main systems have been used in men: the Remex system, the Argus system, and the Atom system. So these are the system where you can increase the pressure to increase the, to decrease the leakage. The evidence is that there is limited evidence that adjustable male slings can cure or improve stress urinary incontinence in men, and there is limited evidence that early explantation rates are high, and there is no evidence that adjustability offers additional benefit over other types of slings. As you can see, the evidence is not very strong with this kind of slings. So this is what is available in the literature for the guidelines. Next. The compression devices in male. We know that external compression devices can be divided into 2 types: circumferential or non-circumferential compression of the urethral lumen. The artificial urinary sphincter is the standard treatment for moderate to severe male stress urinary incontinence. Professor Diaz will give more information about this artificial sphincter very soon now. The non-circumferential compression devices consist of two balloons placed close to the vesicourethral and anastomotic site. The balloons can be filled and their volume can be adjusted post-operatively through an intrascrotal port. Next, please. Although the artificial sphincter is considered to be the standard treatment for men with stress-urinary incontinence, a continence rate of about 80% can be expected. The non-circumferential compression have been had many trials to treat the post-prostatectomy stress-urinary incontinence, but by insertion of these devices consisting of the balloons. And there was the cohort studies that have been described. The functional outcome was as good as 68%, while 18% of devices had to be explanted. Radiotherapy patients will experience lower success rate and higher percentage of urethral erosion. So the evidence say that there is evidence that primary artificial urinary sphincter implantation is effective for cure of stress urinary incontinence in men. Long-term future failure rate for artificial urinary sphincter is high, although device replacement can be performed. There are conflicting data on whether previous pelvic radiotherapy affects the outcome of artificial urinary sphincter. And then let's go to the important point. Very limited short-term evidence suggests that the non-circumferential compression device, the PROACT, is effective for the treatment of post-prostatectomy incontinence, and the non-circumferential compression device is associated with high failure and complication rate, leading to frequent explantation. Next, please. So this is like the overview of the recommendation for men with stress urinary incontinence. As we mentioned, the duloxetine only to hasten recovery of continence, and then only offer bulking agent to men with mild prostatectomy, post-prostatectomy incontinence who desire temporary relief of incontinence symptoms. Do not offer bulking agents to men with severe post-prostatectomy incontinence. Offer fixed sling to men with mild to moderate post-prostatectomy incontinence. Offer fixed sling to men with mild to moderate post-prostatectomy incontinence, I said, and warn men that severe incontinence prior pelvic radiotherapy or urethral stricture surgery may worsen the outcome of the fixed male sling surgery. Offer artificial urinary sphincter to men with moderate to severe post-prostatectomy incontinence. And the implantation of artificial sphincter or PROACT for men should only be offered in expert centers. And this is very important because artificial urinary sphincter and the PROACT are not easy procedures and should be done in expert centers. Otherwise, the explantation rate will be very high and the infection rate can be very high. So please, you have to be careful about this. Warn men receiving artificial sphincter and PROACT that although cure can be achieved even in expert centers, there is high risk of complications, mechanical failure, or need for explantation. And don't offer the PROACT to men who have pelvic radiotherapy. Next, please. So what about the bladder wall injection of botulinum toxin A for refractory detrusor overactivity? Botulinum toxin A 100 units dissolved in 10 mils of saline and injected in 20 points of the bladder wall above the trigone is licensed in Europe and to treat overactive bladder with persistent or refractory urgent urinary incontinence in adults of both genders. So this is the use technique. The evidence of this is that a single treatment session of botulinum toxin A 100 units injected in the bladder wall is more effective than placebo at curing and improving urgent urinary incontinence and quality of life. There is no evidence that repeated injections of botulinum toxin A have reduced efficacy, and there is high risk of increased post-voiding residual urine when injecting elder frail patients. The risk of bacteriuria after botulinum toxin A 100 unit injection is high, but the clinical significance of this remains uncertain, and it is the injection of the botulinum toxin is superior to solifenacin for cure of urgent urinary incontinence, but rates of improvements were equivalent. The importance is that we have strong recommendations here to offer bladder wall injection of Botox to patients with urgency urinary incontinence refractory to conservative therapy, to warn the patients of the limited duration of response and the risk of UTI and the possible prolonged need to self-catheterize themselves. So these are strong recommendations and very important. Next, please. Looking at the sacral nerve stimulation, you all know what is neuromodulation. So I will go directly to the evidence to save time. And sacral nerve neuromodulation is more effective than continuation of failed conservative treatment for cure of urinary incontinence or urgency urinary incontinence, but no sham controls have been used. Sacral nerve neuromodulation is not more effective than Botox 200 units injection at 6 months. They compared it here to 200 units. You have to take care of this. And in those patients who have been implanted, a long-term 50% improvement of urgency urinary incontinence is maintained in at least 50% of the patients, and 15% may remain cured. The use of 10 permanent electrodes is in a staged approach results in more patients receiving the final implant than occurs with the temporary test stimulation. And there is also strong recommendation to offer sacral nerve modulation to patients who have urgency urinary incontinence refractory to antimuscarinics. I think now it is the turn for Professor Diaz to present about the artificial urinary sphincter.
Thank you very much, Sherif. Certainly, as you mentioned, the artificial urinary sphincter is the gold standard for the management of prostatectomy incontinence. It has passed the test of time. It was first introduced in year 1990 with the first designs AMS 791 and after 792 until the current device, which is the AMS 800, which was finally introduced in year 85. So it has passed the test of time. It's the gold standard, but certainly not all patients are good candidates. Good candidates are those who have good manual dexterity, good mental capacity, because otherwise they won't be able to manage the pump, and this is something that we need to take into account. Incontinence should be at least for 6 months, although this aspect varies across the world, because some institutions consider surgical therapy only after 1 year of radical prostatectomy, because after that, incontinence is supposed not to recover. Then we also need a good urodynamic, good bladder capacity, at least 200 cc, urine flow greater than 10 ml per second, low post-void residual, and the patient needs to be willing to undergo the procedure, because if he is not willing to have the procedure, we are going to fail for sure. Next slide, please. So the outcome of artificial urinary sphincter is pretty good. I would say that although many patients would need reintervention sooner or later, the outcome, the good result is obtained in most around 90%. However, the outcome is not the same after radiotherapy, because after radiotherapy has been shown that the outcome is a bit lower, but still, radiotherapy doesn't contraindicate the implantation of an artificial sphincter. But again, I would say that with no radiotherapy, close to 90%, the outcome after radiotherapy is a bit lower, and we have to take this into account. Next slide, please. So regarding the durability, nowadays, the mechanical problems are not so common like in the past. Some patients in the long term might have recurrence of incontinence due to atrophy of the urethra below the cuff. But durability is not an issue anymore. However, we should always be concerned for the risk of erosion or infection, although we never know what is first, erosion or infection. But one the patient has an erosion, obviously is already infected. But the durability is pretty high. I have still patient that I implanted more than 30 years ago, and the sphincter is still working. Next slide, please. The other issue to consider is what to do after a failed sling. And in this study, it was shown that after the failure of a primary sling, the best outcome is again artificial urinary sphincter, because it's clearly superior to a second sling. Next slide, please. So, as previously said, artificial urinary sphincter remains the gold standard for prostatectomy incontinence for neobladder after pelvic floor trauma. Slings report good result, but only for mild to moderate incontinence. Bulking agents do not have durable effects, as Sherif mentioned, and balloons have promising result, but only in the hands of very few people. Next slide, please. There are some other devices. One of them was the Flow Secure, which is not available any longer. This is a device from Switzerland. There's a 5, which has the advantage of being adjustable, because we can put more liquid in order to obtain better continence. From my point of view, is that the pump it's bigger than the AMS 800. The first results, the first published results are not that good, but next slide, please. We presented last year the data of a multicenter study in Spain, observing an acceptable outcome for an artificial sphincter, which is adjustable, because we can promote continence, injecting more fluid inside the system. Next slide, please. But as in the same way that the AMS 800 went through several processes of development and improvement the design, now there is a new one, the Victor plus artificial sphincter, which is still, I would consider still experimental, because there is no good data, but hopefully, because it's adjustable, might play a good role in the next future. Next slide, please. But the ideal artificial sphincter should be that one which admits electronic fusion and prosthetic. It's possible to record the pressure, allows remote activation and deactivation, is easy to program, it's non-invasive, has non-invasive adjustability, simple to use, simple surgery, safe, durable, and a low complication rate. This is the ideal artificial sphincter. We don't have such a device yet, but hopefully in the next future we will have it. So, Sherif, would you like now to go to the first case we have and present? Although I would like to make a question to ask a question to you first, Sherif. You mentioned about the reposition test. My question is, what do you think is more important? The residual function of the sphincter determined by the reposition test, or the severity of incontinence at the time of electing either a sling or a sphincter?
This is a good question, David. The severity of incontinence is really important to judge how far this patient will benefit from either of the two techniques. And as we mentioned, that if the patient is severely complaining of incontinence, I don't think that the sling will be the best option for him. So I will definitely advise him with the sphincter. The reposition technique is good when the symptoms of the patient looks mild or moderate, and if the patient has some criteria of retaining some of the sphincteric activity. And we do this reposition test to make sure that the urethra is, this part of the urethra, the bulbar urethra, is still mobile and can be fixed or applied with the advanced technique. So this is how I think of it.
Okay, let's go to the case.
Okay, so the first case is a 65 years old male with no relevant previous medical history. He got open radical prostatectomy June 2016, and you can see the Gleason score is 3+4, and the pathology is PT3B-R1. It has mild stress-strain incontinence after surgery. After almost 6 months, he was referred to radiotherapy, and again his PSA was monitored for after 1 year or maybe 7 months after. He complains of severe mixed urinary incontinence, so his ICIQ is 18. So what do you think of this patient? How do you see the pathology of this patient after getting the specimen? I mean, looking at the pathology, looking at the PSA and the external beam irradiation, his severe, incontinence. How would you evaluate this, and how would you move to the second step?
Well, yeah, go ahead.
And Sherif, actually, especially for this patient, this has a severe mixed urinary incontinence. So the treatment of post-prostatectomy incontinence can be a really complex process. So we need more investigation, especially the patient had an radiation therapy with severe incontinence, and at least I want to make an voiding diary or PET test that will be clarified to nature of the incontinence for this patient.
Next, please. What would you do as the next step? A PET test. Would you give him diloxetine with his symptoms, anti-muscarinic therapy? Would you like to do urethro-cystoscopy to diagnose better, or to do urodynamics to know better about his incontinence?
Well, I wouldn't go for diloxetine. I certainly will perform a PET test, scope, and urodynamics, because the urethro-cystoscopy is mandatory and before any surgical procedure. And urodynamic is advisable, particularly because these patients have urgency incontinence as well.
Okay, as you can see that he has severe incontinence. His PET test is more than 400 grams, 4 pads per day, maybe 1 to 2 per night. So the patient underwent therapy with transcutaneous oxybutynin with no improvement for 4 months. So he got his anti-muscarinic, but he didn't achieve any incontinence. Would you think that his incontinence here is more due to urgency or more due to the sphincteric deficiency? Next, please.
Well, it's probably due to sphincter deficiency, of course.
So what would you recommend now? Urethro-cystoscopy, urodynamics? Would you apply directly artificial sphincter or sling, whether TOT or adjustable sling? What do you think?
I think I will do both, scope the patient and urodynamics before any further procedure.
Okay, next, yes. And these are the results of the urodynamics. And you can see that the patient, has a few intrusion overactivity incidents, but when he starts voiding, he has real obstruction. You can see that his voiding is very obstructed. So the next step is to do cystoscopy, as you mentioned.
Yeah.
David, you mentioned that you will do your cystoscopy as well.
Yeah.
Good. And then you did this, and anastomotic stricture was found. And probably endoscopic management has been done to get rid of this stricture. Next, please. So what would you do now? Would you go for the sphincter or slings or the balloons?
I will go for a sphincter. After deobstructing the patient, the problem is how long after the TUR to resolve the anastomotic stenosis will go for the sphincter. I would suggest 6 months would be an acceptable.
Emre, next, please. So how long would you wait to perform the surgery? 3 months, 6 months, or 12 months?
I would say between 2 and 6 months, yeah.
Okay. Emre, what do you think about this?
Actually, Sherif, I will wait at least 6 months for this patient, as I agree with David.
Okay, I'll do the same. Okay, thank you. David?
Okay, this is a 70 years old man who underwent laparoscopic radical prostatectomy. He had adenocarcinoma Gleason 3+3 and complained of stress-urinary incontinence in both lying and standing position. Sometimes he can hold urine, needs 2 to 3 pads per day. The ICI-IQ is 11. The pad test is 200. And he underwent conservative therapy without improvement for the time of 6 months. Next slide, please. So this, can you go back one slide, please? So the patient has a prostatectomy incontinence with mild incontinence, 2 to 3 pads per day, and the pad test is 12. So then next slide, please. So the issue now is to decide what we do. Conservative therapy, pharmacotherapy, more investigation, advanced sling, and wait and see. So what would you suggest?
I think that he can take either deloxetine or antimuscarinic therapy, and then to apply more investigation if this is not resolving his problem.
But why would you use antimuscarinic therapy if the patient has no urgency?
Sometimes there is a sort of intermittent urges that happen to the patient when, especially with the trickling of urine in the. So sometimes it helps to relax the bladder more and give more space for the urine to keep there.
Yeah. Well, that's then this is the Sherif. This is next slide, please. So this is a candidate for a sling procedure, either advanced or any other one. So this is the reposition test. We talked about this earlier, and the issue is that some groups, some institutions consider the reposition test as the main outcome predictor of the advance, meaning that the patient has no positive reposition test will not respond to advance. I doubt that this is the case, but we don't know. For me, the most important outcome predictor is severity of incontinence, and that the patient is continent in the lie down position and has no radiotherapy. What do you think?
I think it is important, if you are deciding to put the advance, it's important to do the reposition test. It helps and gives you a very good idea of the possible outcome.
Yeah. And Sherif, will you prefer to do the reposition test if you do the fixed sealing, not advanced, not the retrourethral sealing? Will you suggest to do the reposition test?
I think the reposition test is helpful with the advanced sling.
Okay.
And Sherif, do you think that it's important to cut the central tendon?
With the advance, I think yes, because it helps you to fix the mesh in this area, and to make sure that when you do the test intraoperative, to make sure that it is really coapting the mucosa properly.
Okay.
Actually, I have one question from audience. How you select a reposition or compression sealing or adjustable sealing? David, can you say something about that?
Repeat the question, please.
How you select reposition or compressive sealing or adjustable sealing?
I don't understand the question. Well, the way I do is when I'm performing cystoscopy, I'm looking at the ureteroscopy. I push in the perineum and see whether or not there is a compression of around 1 centimeter length. But I don't know if that responds the question.
Okay. And Sherif, one more question from audience. Such cases, and do you perform a urodynamic study prior to any surgical treatment for post-prostatectomy incontinence?
I will definitely do urodynamics before Botox injection before putting a sling or artificial sphincter.
Yeah, I agree.
Okay.
Okay.
This is our.
Emre, we have another clinical case. Would you like to introduce it?
With pleasure, David. Thank you. And the patient, 69 years old male, who underwent laparoscopic radical prostatectomy 2015 with the pathology P33A. And he had a PSA persistence after surgery and underwent external beam radiation therapy. And no response to 6 months of conservative management plus antimuscarinics, and the complaints of mixed urinary incontinence. And he had a 4 PETs day and 1 or 2 night PET test, 550 cc, and ICIQ test is 20. What would you do next for this patient? Add on myrobackground or Botox injection, or urethral cystoscopy and urodynamics? And maybe we can start with Sherif if you want.
I will start with myrobackground, of course, and definitely with urodynamics to make sure. To prepare myself if I'm going to decide on more aggressive or surgical intervention, like sphincter or whatever. So myrobackground as a start with urodynamics.
Yeah, I agree. I agree with that. And so we have to, sooner or later, we have to determine what is more important, that the urgency component of incontinence of the sphincter deficiency. Because most of the time, in 1/3 of cases, patients have both. In this case, the patient seems to have the trussal sphincter deficiency together with the trussal overactivity. So, go ahead.
You can see here on the trace that there are, phasic uninhibited contraction and phasic trussal overactivity, and at the end, there is terminal trussal overactivity that push the patient to start voiding. And it is quite clear that there is real urgency in incontinence with the sphincteric problem.
So, I have a question, especially for this case. Do you satisfy with the bladder capacity for these patients, or any suggestion you can suggest us any to show the functional bladder capacity? And can you say something about the David?
Well, ideally the bladder capacity should be higher, but this patient have mixed urodynamic incontinence, and we have to deal with that. If he hasn't responded to pharmacotherapy, in my experience across to my entire life, I have seen patients with the same clinical picture who do very well after artificial sphincter, which means to me that the trussal overactivity is not a contraindication for artificial urinary sphincter, because many patients do very well, even those with low bladder compliance. So I will do an artificial sphincter in this patient because the severity of the incontinence and not an adjustable sling, of course.
This is true, and also I want to add, Emre, that during urodynamics, if the patient has real urgency incontinence and severe trussal overactivity, you might not be able to make good filling of the bladder sometimes. But while after giving some treatment like mirabegrone or antimuscarinics or whatever, and with the sphincter in place, the bladder starts to gain more capacity. If not, you still have the chance to go with the flexible to inject a Botox or whatever. So, this shouldn't be a contraindication.
Okay, I understand from you, Sherif, from your viewpoint. So, and you do not suggest the Botox injection if the bladder capacity is low to increase the bladder capacity for sphincter. We had a very good question on that. And what would you do next for this case? Maybe you can summarize.
As mentioned by David and myself, that this patient has severe incontinence, and it wouldn't be helped or cured with antimuscarinic alone or mirabegrone alone. So I think that we have to plan for artificial urinary sphincter together with either and a combination of antimuscarinic and mirabegron or injecting botulinum toxin.
Okay. David, any more comment on the case?
I completely agree. So we have to do and see what happened. But this patient has a terrible life with this, that's a severe incontinence. So artificial urinary sphincter and maybe Botox after that.
Yes.
Okay. Actually, I have one question from audience I would like to ask. What is the, maybe this can be the case by maybe the other question related to other cases, but what is the minimum evaluation of for post-prostatectomy incontinence? Because today we talked everything about the related to guidelines, but this is the one question I think it's really good. What is the minimum evaluation of post-prostatectomy incontinence? Can you give a very brief answer, please, David?
Yeah, I think we need the proper clinical history to make sure that the patient is capable to handle a sphincter if we go for a sphincter. Second, we need to know the severity of incontinence, because if the patient has severe incontinence, he would rather need an artificial sphincter. If the patient has mild incontinence, well, might be candidate to a sling. And what is mandatory is cystoscopy. Urodynamics, I mean, we might avoid urodynamic. We like to do urodynamic because it gives us full information, and we will perform treatment based on the knowledge rather than intuition. But it's not always possible, so we might skip urodynamic, but certainly cystoscopy is mandatory.
Mm-hmm.
Okay, Sherif, you have?
If you want to ask me the minimum, so yes. I would tell you, as David said, full clinical history and the PAT test. With these two items, you can get up to 80% of the information, and you can start to give conservative or non-surgical treatment. But if you're going to turn to surgical treatment, then I would advise to do cystoscopy and urodynamics.
Yeah.
And I have one more question, and then maybe it's also good. In case of mixed urinary incontinence and decided to do Botox and sphincter, what if he developed urinary retention? What is your advice regarding clean intent catheterization? David?
Well, that's not the problem. We have many patients with symptomatic catheterization, particularly neurogenic patients who we used to do blood augmentation plus sphincter. Many of them stay in retention, and then they need to perform intermittent catheterization. It's perfectly possible. Patients need to deactivate the sphincter before passing the catheter, but it's a possibility. And the same regarding the need of botulinum toxin injection with flexible scope. It's possible to do it without damaging the cuff.
Okay, Sherif?
I agree. They're the same. It's you have your tools, and you can manage. I mean, the case according to your to the given data. So if you want to do injection, you can go with the flexible. You can if you have retention, you can ask the patient to do self-catheterization, and you have to inform the patient according to the guidelines that this can happen, and they have to be oriented and consented for this. So, I mean, there is no surprise.
Okay, very good. And actually, during an hour, we have many messages for our colleagues, and really we learned too much from this good viewpoint. I would like to summarize and take home messages. COVID-19 has clearly impacted the care of urological patients, and in particular those with post-prostatectomy incontinence. So this is fact. And the prevalence of post-prostatectomy incontinence depends on the definition of continence after radical prostatectomy. And there is a need still better define the concept of severity of the stress urinary incontinence after radical prostatectomy, and the conservative and the medical treatment shorten recovery time, but do not cure stress urinary incontinence. Sealings are still good option for patients with some residual function of the sphincter. and the sphincter still goes as a gold standard and pass the test of the time and continue to be the gold standard. And finally, the new technologies like in 3D modeling, the 3D printing, they are new research topics for surgical planning and the training and the education. Actually, on behalf of School of Modern Technology, we would like you to invite you our cadaver and 3D printed course that will be held in 5 to 7 November in Istanbul. And we will evaluate everything. And now we will jump to closing remarks. Actually, I will open my camera. Finally, many thanks to the panel for today, and please look at the ics.org/live for the other upcoming live events which are being put on by ICS and during this lockdown. Actually, I personally thanks to ICS office for the opportunity and with great contribution, although the COVID-19 crisis. And Professor David Castro Diaz, Professor Sherif Mourad, special thanks to you. And I would like to request from your side closing remarks. And Sherif and David, please, your closing remarks.
Okay, thank you, Emre, for organizing this, and thank you, David, for sharing with us today. I want also to thank the ICS for the continuous effort they are doing to keep, our doctors involved during this hard time of the COVID-19. I'm very happy to be with you today, and I hope that the audience enjoyed this. Thank you very much.
Thank you very much, Sherif and Emre, for this beautiful